waiting. Some people may be coming from other meetings, and I think we will just go on. Let us just remind ourselves about a few housekeeping issues, like please ensure that you mute your microphones if you're not speaking. Also, if bandwidth permits, please turn on your video. It helps make the session lively. Use chat at any time to introduce yourself, ask questions, or make some comments. This will keep us moving and know that people are still following. Enable subtitles on your screen as needed, and sessions are recorded. So recordings are sent out after each session. So feel welcome. And we are just going to have one of our own, that is Julia. Julia Donning is a registered nurse. Julia is an experienced palliative care nurse, educationalist, and researcher. She's the chief executive of the International Children's Palliative Care Network, that is ICPCN, and professor at universities in Uganda, Serbia, and the UK. She has extensive experience in global palliative care, research, and education, and it is on the editorial board of eCancer, APN, and the IJPN. She has worked with palliative care for over 30 years, with 20 of those working internationally in Uganda, Africa, Eastern Europe, and globally. Professor Donning serves as on several boards of NGOs, including the International Society of Nurses in Cancer Care, the Worldwide Hospice and Palliative Care Alliance, and the Africa Palliative Care Association in the UK, and is an advisor to the International Association of Hospice and Palliative Care. She's also part of the steering group for the EAPC Children's Palliative Task Force. Welcome, Dr. Julia, as we prepare to hear from a wealth of experience that you hold. Karibu sana.
Asante sana, Pamela, and it's great to be here with everybody today. And thank you very much for the invitation. And it's great that we are able to think about palliative care and think about palliative care for children with cancer across the region. And in the next 10 minutes, I'm just going to share briefly a few thoughts around palliative care for children with cancer across the region. And really importantly, as we think about this, we think about what we're aiming to do. And through palliative care, we're hoping to increase the quality of life of children, such as these two who were in our palliative care program, so that the time that they have, they are able to have a good quality of life. And I think that's always a challenge for us when we're thinking about caring for children with cancer. Many children and their families have to travel long distances to access treatment. Many families will, even if treatment itself is free, will get into poverty due to the parents not being able to work as they're caring for the child, transport, accommodation near the hospital, a wide range of issues. So there's a lot for us to think about as we're thinking about palliative care for children with cancer across the region. I think it's always good to start with the World Health Organization definition of palliative care. And there's various things I like about this definition. I'm not going to read it out. I think you will get copies of it. But it talks about palliative care being the active total care of the child's body, mind, and spirit. And it's also supporting the family. Too often we hear, "Oh, there's nothing more that we can do for you." And within palliative care, there is always something that we can do for the child and their family. It might not be cure, but we can support them, and hopefully we can help improve their quality of life. It's about the physical, psychological, social, spiritual, and cultural. So care needs to be put in perspective. It's very much multidisciplinary, and importantly, it can be provided wherever we find the child and their family, whether that's in a tertiary referral centre, whether it's in a hospital, in a health centre, in the child's home, in the community. Wherever we find the child and their family is where we can provide palliative care, because palliative care is a philosophy of care. It should be provided across the continuum of care. So it should be provided across different health settings. It should be provided from diagnosis through into bereavement. And for many of us, or for many children, it might not even include a diagnosis. We know that around 80% of children with cancer present late across low middle income countries in sub-Saharan Africa. Some may not get a diagnosis. So whenever the child presents for care is when we can start providing palliative care. And importantly, it must be an integral part of all pediatric cancer care. It's not an optional extra. And we see that it is a core component of a national cancer control plan. So children's palliative care is an essential core component of pediatric cancer care. And importantly, palliative care is about living. People think it's all about death and dying. That is an aspect of it, but it's about living. It's about enabling the best possible quality of life. So if we think about the childhood cancer care pathway, and this pathway comes from the WHO's Global Initiative for Childhood Cancer, the GICC, we can see that palliative care is an important part. And if you look at the World Health Organization documents on a national cancer control plan, again, palliative care is key in that. And one of the models that we look at in terms of the provision of palliative care is what is known as the bow tie model, which shows that palliative care is provided right from the beginning of the provision of care, but it increases as treatment-related cure decreases, the need and the amount of palliative care provision increases. But very much an integral part, the two very much go hand in hand together. So what are some of the principles of palliative care in children with cancer? Well, as I'm sure you're aware, we could do a 1, 2, 3 week course on this itself, but just identifying some of the principles. We've said that it's across the continuum . How do we make sure they are included in the care? Financial issues. We know, particularly in low middle income countries, that many families with a child with cancer just go into a spiral of poverty. How can we support them? And importantly, teamwork. But we also know that there are barriers and challenges to the integration of children's palliative care into cancer care. There's often a lack of recognition of the need for palliative care, a lack of policies. There might well be policies around cancer for children, but does it include palliative care? Does the National Cancer Control Plan include palliative care? Is palliative care integrated into all the health services? For many, we find there's a lack of access to education on palliative care, a lack of access to medications that we might need, a lack of access to trained professionals. We know that there are challenges across the region on access to medicines, access to the use of opioids, fear of the use of opioids, as well as other pediatric formulations. And we know that there are often a lack of resources. Because the challenge we have in many countries in the region, even where cure is theoretically possible, it's often not realistic due to the uneven distribution of services. We've mentioned the children presenting late, expense, awareness that children's cancer can be treated, awareness that palliative care is available, the technical skills and expertise, and I've already mentioned the lack of recognition of the need for palliative care and a lack of policies. So the World Health Organization looked at a new conceptual model for the development of palliative care, both children's palliative care and adults palliative care. And this was published just in 2021, building on the previous model for the public health model for palliative care development. So this identifies the core components in developing palliative care for children with cancer, and empowered people and communities, health policies, the need for research and data, and then the use of essential medicines and education and training as key pillars for the provision of palliative care through an integrated health service, and ensuring that children and their families, children with palliative care needs, are at the center of the care that we provide. So just to highlight a few of these issues, this is a map that was published in the Lancet Commission report in 2017 and 18. And this just demonstrates opioid morphine equivalence. And you can see that in much of sub-Saharan Africa, it's disappeared. Where is it? Because of the lack of access to some of the strong analgesics that we need. It's not just in Africa. You can see many other parts of the world are missing. But then there are parts such as Canada, USA, Australia, where more than anticipated has been used. And so we have this challenge in some places, such as in the US, there's challenges with the misuse of opioids. In other places, there isn't access to opioids. It's called the dual epidemic, overuse and no access. Education and training, there's a wide range of education and training programs now. This is just an example from the ICPCN, free online training on different aspects of children's palliative care, and education and training across the region is growing, as is the range of research. And these are just examples of research that has been done across the region. And it's exciting to see how research in children's palliative care across sub-Saharan Africa is now leading the way and directing research in other countries. So, for example, the Children's Palliative Outcome Scale was first developed across sub-Saharan Africa, and now our work across the region is being replicated in other places. So we need to increase the evidence, and you can see here that the evidence on children's palliative care, and this is globally, not just in sub-Saharan Africa, is growing, and the evidence in children's palliative care in sub-Saharan Africa is also growing. And that's exciting to see, but we need to continue to develop that, to continue to develop the data so that we can implement evidence-based palliative care for children with cancer. So finally, in this quick overview, just to mention the International Children's Palliative Care Network. We're the global network of individuals and organizations working together to reach the estimated 21 million children that need palliative care around the world, with only around 5% actually currently accessing palliative care. So please do join us. You can join, membership is free on our website. So children's palliative care is an integral part of caring for children with cancer. And as we prepare our cancer control programs, as we develop our integrated services for children with cancer, palliative care needs to be there and is a core component of that. Thank you.
Wow, thank you very much, Dr. Julia, for that wonderful presentation. And you have really kept within time. I just started warning you that you have 4 minutes, 3 minutes, then you surprised me before I rang the bell. If we have questions, we can put them on the chat, or you can keep them for our discussion time. So I would like to take this opportunity once again to welcome Dr. Mfo Rashikana. Dr. Mfo is a palliative care physician and director of the Center for Palliative Care at Chris Hani Baragwanath Academic Hospital and the Wits Center for Palliative Care under the School of Clinical Medicine, University of Witwatersrand in Johannesburg. Having moved around the health system over the years, Dr. Mfo has over 15 years of experience in palliative care and has a special interest in spiritual care and is an advocate for increasing access to palliative care for those in need. Dr. Mfo is currently working with a number of countries in Southern Africa, focusing increasing palliative care access and training of professionals. Welcome, Dr. Mfo.
Thank you very much, Pamela, for the introduction, and good afternoon to all colleagues. I'm going to be giving you a presentation on the work that we're doing here at Chris Hani Baragwanath Academic Hospital, and this will be my outline. I hope I'll be very short. I'm going to start by showing a picture of this wonderful gentleman who lost his wife in 2000 and recognized the need for palliative care. And I usually say, until you have been hit, you are not able to recognize the need. And he said something that I've highlighted here to say, they were making a diagnosis. They were instituting appropriate treatment for those who were potentially curable. He was talking about cancer here. And he said there was little they were offering for people who were not amenable to curative treatment. Professor Ken Hartle was the head of internal medicine at the time, and I use him as my role model. And I've decided to put this stepwise process that we had to undergo for us to be able to ensure that palliative care is accessible, at least in the area where we are working. For those who are not aware, Chris Hani Bara is the 3rd largest hospital globally and the largest probably in Africa. And when you look at where we started, Prof. Hartle is here, 1999. He sent someone to the UK to study palliative medicine. This was for adults. 2003, at the height of the apologies, at the height of the HIV pandemic, a gynecologist found the need and decided to get funding to have an outreach program. 2007, Michelle Meyring, known to most of you here, started the Big Shoes Foundation and started pediatric palliative care. 2008, combination of the adult, the pediatrics, everyone, there was a political buy-in from Chris Hani Bara Hospital, from the senior management, and also political lead from the Gauteng province. This is not yet national. 2011, we then established the center under the university where we are training both undergraduate and postgraduate. We also have short courses that we are running. And in 2013, the pediatric program, because Dr. Michelle Meyring moved to Cape Town, and after that handed over the big shoes to someone else. 2013, it was incorporated as part of the Center for Excellence in Palliative Care and the Gauteng Center of Excellence. 2017, only then did we have a policy in the palliative care in the country. But look at the work that has been done. Okay. This is our vision and mission. We are aiming to provide equitable palliative care for all who need it, whether they are children, whether they are adults. Okay. And we Our model is a specialist palliative care model. This is also was adopted by the policy, our national policy, because we have different models. So we provide consultative services within the hospital in different wards, and we also train, we also mentor, we do a lot of research, collaborate globally, and there's a lot of advocacy that we do. And I use advocacy to be able to raise funds, to be able to increase access to palliative care. And there's a lot of awareness that we also do. And all this we do to ensure that there is continuum of care for both adults and pediatric patients across the different levels of care. Okay. This is our organogram. And here I just want to highlight the public-private partnership that is enabling us to be able to provide services. The orange here is these are government funded posts. Everyone in orange is funded by the government. Everyone in green is funded privately. The purple one there is these are lecturers who are funded by this university. Okay. This slide is showing you one of our champions. This is Dr. Minas Ali, our pediatric palliative care doctor who is working in the pediatrics. And this slide she uses when she is doing the training, in-service training for our healthcare providers. And she explains here the role of the palliative care team. And I think you can see all the aspects that we focus on in palliative care. The social workers are there, we pray, there's a lot of advice and all that. And this is the team, some of the team that we have. You see, this is our social auxiliary worker. This is Witumelo, one of the chaplains, and this is the second chaplain in uniform. So we have a very small team who are providing the pediatric services. However, they receive a lot of support from the nurses who are paid by the government, because we've got nurses who are pediatric trained and all that. We do not have hospital beds for both adult and pediatric. We provide services in partnership with the treating either physicians, surgeons, or pediatricians. Okay, and we collaborate a lot with local organizations. There's Lambano Hospice, there's CHOC. You cannot provide palliative care services without working with other stakeholders. Okay. And these are some of the activities that we have. We provide pain and symptom control in the different hospitals. In the previous slide, I indicated that the small pediatric team provides services at Chris Anibara Hospital. They go to Rahima Musa, which is a maternal and child hospital. They also go to Nelson Mandela Pediatric. They also go to Charlotte McClake. So you can imagine how stretched they are. And here under social support, there's a lot that they do: bereavement, counseling, family meetings. And you see Nongosi again here. These are our grandmothers. We also have a support group for grandmothers. Unfortunately, Mason Sonto passed away a few years ago. Under social services, we also have bereavement services or healing services. This is the Tree of Life, where they will put in those they have lost. So this is one mother who has lost a child, and they had come in for this service. We also have chaplains and spiritual care providers who are able to support our patients throughout the care when we are providing services. Part of what we do, because we are part of a tertiary institution linked to Wits University, there's training, undergraduate training, there's also in-service training. As the center, we also provide postgraduate training, but for pediatrics, all the involvement of pediatrics here is only for undergraduates and in-service training. And these are some of the trainees. I think this is Eastern Cape here. They also support children in the communities. Some of them are family members of the children who are our patients. Some of them are just family members. And here we also provide food parcels for those because of the challenges of poverty that we have. This, for me, is one of the most important slides in this presentation. Advocacy. I spoke about the fact that I advocate for resources. We continue to advocate for resources for pediatric palliative care and also for adult palliative care services, because access is an issue. Access to palliative care for those in need is still a challenge in South Africa, despite the fact that we have been providing services for all these years. Part of advocacy, again, just talk for me, I usually say, wherever you are, just talk about palliative care. So from talking to colleagues and all that, to date, I can say proudly, we have 5 pediatricians who have been trained in palliative care. For now, training is only happening in University of Cape Town. So I think that in the last 2 years, we've had five pediatricians. We've got pulmonologists, oncologists. Here at Bara, I know that there's an oncologist who trained last year. We've got neonatologists. We've got an HIV specialist in Rahima Musa. And together with Dr. Ali, they're providing weekly ward rounds for our patients. The other advocacy that I continue to do, because we are governed by the Palliative Care Advisory Board within the university, I present on the progress that we do, and I continue to advocate for palliative care to be expanded. And I think from the last 2 meetings that we had, the head of pediatric palliative care took it upon himself to say he is going to make sure that pediatric palliative care is actually governed by pediatricians, which I think for me is a big milestone. We also continue to do the global awareness campaigns locally, and I'm sure you can see us here with our nice hats during the Hands-on for Pediatric Palliative Care. And as part of advocating for resources, we were having the Rotary in our area here donating a container that the grandmothers are using, because as you can see up here, they're busy in our office doing beadwork to keep themselves busy and also to raise funds. So they were donated this container here for them to go and meet there and do their work. The bottom picture here, our grandmothers had been invited to go to Durban to attend a global grandmothers gathering. And I think you can see here in South Africa, we call this doi. You go out in the street and go and make noise for people to be able to hear what you are saying. And now I have a few recommendations. For those who would like to start, whether it's adult or pediatric palliative care, don't wait for government, don't wait for policies. As long as you have passion and you want to start, go and knock in somebody's door. They'll be able to listen, give you some startup funds for you to start. So I usually say, don't wait for government. If we could have waited for government, we would not be here for 22 years here at Chris Hani Bara. Okay, identify someone with a passion, because if in your setting, you still do not have a policy, you still don't have palliative care, it means someone who's trained thought it was important. So identify a champion, someone who's trained, whether it's a physician, whether it's a nurse, they will be able to run with the program. Identify local support structures. They are there to be able to make sure that you do not fail in what it is that you are doing. For those who are not aware, South Africa relied on hospices for a very long time. HPCA was providing palliative care as a non-governmental organization, and government bought in much later. I think they bought in after more than 30 years when HPCA had been doing the work. So identify local structure. There are people who are doing good work in your area. The other part is that when you decide that you are going to start and you're going to train, not everybody has a heart for palliative care. There are people who are sent for training here, in service training, and literally they come in, they warm the benches. You don't want someone who's going to warm the benches, go back and not implement. Identify people who have a passion for palliative care. Those are the ones who will be able to run with the program. And then I just want to say, I'm sure you realize that I haven't mentioned challenges in my presentation, because challenges are many. You will never be able to address all your challenges. However, my encouragement to you here is to say, just start. When you start, people will come and join you later. Policies will follow you later, and then you'll be able to showcase, because the need for pediatric palliative care is huge out there. I think this is my end of my presentation. Thank you very much, colleagues.
I can attest to it that that was a wonderful presentation. Thank you very much. And I believe from the comments that we are seeing on the charts, that is a very wonderful presentation. So I open this forum for questions in case someone has a question. And also we can still read also through the chat. The chat, most of them are, I can see most of them are comments, except about the availability of, about the opiates, which someone has commented and said that the opiates are also associated with okay, there is lack of opiates, which maybe could be contributing to less palliative care settings, but also the comment has come up saying that opioids also are feared because of addiction. I don't know what you can say about that, Dr. Mfo.
I think Prof. Julia will also add. The opioid phobia, she mentioned it in her presentation. The fear of the fact that opioids are going to cause addiction and all that are there. However, there is a lot of evidence that to say that in the case of palliative care, when patients are in pain, the addiction is minimal. In my setting, I will not lie, over the years, I have never seen a patient who has been addicted to opioids because of the work that we do or because of the prescriptions. So opioid phobia is there because health professionals and also patients will be fearful. However, evidence says patients who are in pain, and if you have assessed your patient well, evaluated your patient well for pain, the risk is very low. Prof. Julia, I think you can add.
Yes,
Yeah,
I mean,
Julie.
it is one of the fears that people have over the use of opioids, particularly morphine. And this is why when you look at that WHO conceptual model, that education and training is really important, and empowered communities and families is really important, because as Dr. Vachikana said, you know, as there is very little evidence when morphine is used appropriately in children's palliative care, with proper assessment, proper dosaging, and careful dosaging. There is very little, there's no evidence of addiction. And what we're finding is, if you look up about this dual epidemic of, there is this, there's a very loud voice and a big voice around the overuse and the non-medical use of opioids, which is causing addiction, etc. And that voice has become so strong that it's impacting on increasing access to opioids and other medications for those who need it. You know, if you think only 5% of 21 million children have access to palliative care, that's an awful lot of children who are suffering in pain and with other symptoms because they can't access the treatment that they need. So we have to get the right balance, and we do have to make sure that our health professionals are trained in how to use the medicines, but then they need to be trained in how to use any medicine. And if you look at the recent guidelines for managing pain from the World Health Organization, they talk about opioid stewardship, which is around the proper usage of opioids to ensure pain management in children, particularly in children's palliative care. And the World Health Organization is committed to this and is also doing work re-looking at ensuring the balance to make sure that we have access to the pain medications that are needed around the world. So it still remains a challenge, and education and training and sensitization is key to that.
Thank you very much for that elaborate explanation. Pediatric palliative care is not an old concept, especially in the lower and middle income countries where Kenya is, and maybe Uganda and these other countries, compared to the developed world. I don't know what is your take on this, Professor Julia? How are we going to work together, because the child who gets cancer in Africa is the same as a child who gets cancer in a developed world. When it comes to care, we realize that at some point we are getting into palliative care, but the palliative care aspect in pediatric, in low and middle income countries, is not given a huge concept as it is in the developed world. What can you say about that, Dr. Julia?
So I think that is also around education and sensitization, and also working with our health professionals. You know, I think I said early on, people say there's nothing else we can do. People think that palliative care is giving up on someone, and it's not at all. And so there's a whole change of perception that we need to try and work on within our cancer care programs. Yes, we have the means to cure many cancers, but as we've already said, many of our children in Uganda, Kenya, across the region present with advanced disease because the whole process of them being diagnosed can be long and drawn out. So many will present with that advanced disease when cure is no longer an option. So we need to be making sure that palliative care is in the training for all pediatricians, that it's part of any fellowship program for pediatric oncologists, for pediatric oncology nurses, that it's so education. I know I keep mentioning it, and Dr. Ratchikana also mentioned it, but education is so key. Children's palliative care is not giving up. Children's palliative care is about ensuring life, ensuring that the children have their best possible quality of life and their families, ensuring that we can manage their pain and symptoms. Children with cancer, but no child should be left suffering in pain or with unmanaged symptoms if we can manage those. So yes, but I think also it's important to remember that maybe in some countries, like in the UK, children's palliative care is quite well advanced. I was in another country in Europe recently where their health minister said to me, "We don't need palliative care, our children don't die." And we had to do a quick and dirty study to show them that sadly they did need palliative care. So, you know, many countries in the region are actually doing really well in terms of advancing and developing children's palliative care. And there are many places outside of the region that are learning a lot from countries within sub-Saharan Africa.
Thank you. Any comment from Dr. Mfo?
I think Prof. Julia has covered most of the issues. That's why for me, I usually say advocacy happens at a dinner table. Wherever you go, make sure that there are people who have authority to approve and to disapprove. So these are people I would usually say, go and sit and have tea. And then when you explain to them, give practical examples of the suffering that our children are going through. Only then do people start realizing that this is important. I'll give another example, but this is from the adult side. I had a discussion with someone who's responsible for the wellness of all government employees in the Gauteng province in South Africa. And when I presented the issue, we were actually in Gauteng, and I spoke about what I do and all that. And then he looked at me and said, you know, our patients, no, our staff members recently are dying of cancer, and we don't know what to do. So there's someone who can make a decision, because she sits in the premiers of the premier is the highest political head in a province. So there's someone who can go and say, I'm responsible for wellness, but we actually have not even put a budget for looking after adults. So exactly the same thing happens to children. If we don't go and knock and tell those who are supposed to be decision makers, they will never budget for palliative care in children. The position that sometimes we get, we should use it positively. Maybe it's the way we present some of the issues, because in the Palliative Care Advisory Board, all heads of departments sit, academic heads. So the academic head for pediatrics is always there, very supportive, but nothing has ever happened over the years until I decided to change the phrasing of the challenges. And I said, I'm sure you realize that I have removed advocacy or challenges related to pediatric palliative care. I've decided I'm not going to talk about it anymore because I've been saying it over all these years. And that then sparked the interest of everyone to say, why are you not talking about it? I said, pediatricians know the need. They will call Dr. Ali and Nongosi, but none of them is prepared to budget to give us resources to be able to make sure that this has increased. And following that, then the head decided to say, no, I'll take it upon myself to make sure that everybody is going to make sure that pediatric palliative care is prioritized. So I think we have an opportunity everywhere. Maybe the way we talk about it is, people will always say, we always complain. That's why I say, maybe we need to change the language that we use for people to be able to realize that, no, there's a need for us to be able to do this. So I'm hoping that a few years, maybe next year also, I'll be able to say to you, we have the 5 pediatricians have actually taken up pediatric palliative care in the vets cluster to be able to make sure that pediatric palliative care is made accessible for children. Thank you very much.
It is, it's the advocacy is so important. I can give you an example in Uganda. I was in the car with Rose Chiwanuka, who's a palliative care nurse in Uganda, and one of the champions. And she had a phone call. This was a few years ago. She had a phone call from one of the ministers. And the minister said, my mum's sick. I need the help of a palliative care nurse. And she put the phone down, and we didn't quite cheer, but we almost did, because that was the senior minister who was in the power to make decisions, who had recognized the need for palliative care. Now, it might have been palliative care for adults, but for children's palliative care, that's still so important. So take every opportunity you have. It's so key.
Thank you. Thank you, Dr.
Can I just add something, because of the, as I say to you, we advocate, and you will be invited to a conference or to I was invited to a partner meeting. I played a very minimal role, and somehow they made a mistake of giving me a platform, and I did not waste my time. I put it out there because there were a lot of oncologists and all that, and I think I was the only person who was representing palliative care. And I explained to them what we do. I presented our model, and I said to them, all your patients here actually need palliative care. From that day, the funder decided to say, all the partners must provide palliative care. That's why I'm able to train across different countries. So you do this, you open a door for something else. I think, Julia, you probably know Johannesburg Hospital, it's called Charlotte McLaughlin.
Yeah.
They would get funding for palliative care, adult palliative care, and then it would collapse. But a number of, I think, over the years. And with the same funder, we had to then get a grant and say to them, we are going to give you this money. We will mentor for 3 years. After that, take over the services. And what I'm seeing now is change in management. And in one of the meetings, the clinical director actually said, next year, we need to start planning for pediatric palliative care. So already I know that there is already a breakthrough in that area.
Yeah.
So really make use of every opportunity.
That is what advocacy can do. Yeah. So it is just making use of the opportunity when you get it, and then push your point forward. I remember when we were about to start oncology services in Moi, when we were still struggling, pushing through it. You're being told no budget. why is this one is only interested in the dying, and all these things. So when I one time got an opportunity to speak to some partners, some prospective partners, so I gave the talk, and that time there was support for those who are having HIV-related malignancies, but no support for those who did not have cancer. So in my closing remark, I told them, this cohort have HIV, have cancer, have support, have transport, have food, they go home happy. This cohort have cancer, they do not have support, they do not have anything. Do I tell them to go and get HIV so that you support them? And everybody said no. Then we started getting some support for our cancer and non-HIV cancer. So any opportunity that one gets can be a good opportunity for advocacy. I can see a question there, or someone has a comment before I read the question.
No, I was just going to say, they call it, I think, having your elevator speech ready. So if you were stuck in the lift, or if you got in the lift with a key person and you have a minute, what would you say? So just always being ready, isn't it, with your, like, this is then you get to a point, like I walk into a room sometimes and somebody will go, oh, here comes Julia, we mustn't forget the children. Now I want them not to forget the children when I'm not there as well, but that message has got across.
Yeah, you have your bullet ready to shoot whenever there is an opportunity. That is the bullet for advocacy, especially for palliative care, and especially our children, whom are always silent sufferers. Now I can see, let me read this question and then I come up with just something on communication. How do you increase the dose of morphine when titrating to patient's pain level? For example, you give a patient 10 milligrams of morphine and she says it is not touching her pain. Do you increase the dose immediately or wait some time before increasing the dose? That's a question from Isaac Lawal. Prof. Julia?
Well, I think Dr. Rachikana, you could answer that one first and I'll add any comments. Okay. It's a challenge because it's managing pain is we've been talking about education and training, and that's key. So over to you, Doctor.
Okay, thanks, Julia. The principle is that I'm assuming that because your patient is already on morphine, the patient has severe pain, because that's where we start. So you look at your 24-hour morphine. If the patient is on, for adults, we'll say maybe MST, they're on 10 milligrams twice a day. That would be 20 milligrams. Now you check whether the patient has had other morphine syrup in between. Let me give an example of 10 milligrams, and the patient had 4 doses. 10, 10, 10, 4 is 40. So your patient will be having, your total dose will be 60 milligrams. The calculation that you are going to make, the principle is that you are going to increase your dose. Your patient was on 10 milligrams. You're going to increase your dose by between 30 and 50%. We review your pain. If your patient is admitted, you review it every day because the patient is in the ward. So by the following day, you are supposed to be able to know this dose is not, the patient is not responding, so you can then titrate up. This is the formula for titrating the morphine syrup. I'm hoping that is clear.
Thank you.
But this is what we teach when we do palliative care training.
And there's the whole issue around, assessing and understanding the type of pain, and whether you need to use adjuvants or not, and using the 2 or 3 step ladder. So it's really important that people are education and training is there.
Okay.
Thank you.
Sorry, Pamela. Sorry, Pamela. After you have increased your dose, never forget to have your breakthrough dose.
Mm.
So you always give that, and then there has to be a breakthrough dose in case the patient is going to have breakthrough pain. Okay, thank you.
Okay.
I think the important thing is that it can be done. There is a formula for doing it. There's a way that we can work it out, and that we can increase dosages safely and carefully, and integrate with other medications as needed.
Thank you. Thank you. I can see time is really not on our side, and that's a very interesting topic. Ishak, do you still want to say something? I can see your hands up. Can you hear me?
Yes, I can hear you. If time will permit, I'm a gynecologist in Nigeria.
Mm-hmm.
He needs to type it because we can't actually hear him.
Yeah, I think the network is an issue. Just type it again the way you typed the app. Okay. Hello?
Hello.
1 minute.
Yes. Hello, everyone.
Yes.
Okay. I just wanted to add on the question raised. For example, I'm taking care of the patient who is on 10 milligram dose of morphine. So if the patient is taking it at 4 hourly and there is a breakthrough pain, so that means if a patient is given 10 milligram dose and then before the 4th hour, there is a breakthrough pain, I have to give the same dose. And then I give at after 4 hours, I give. And then when the patient has breakthrough pain, through 24 hours, I have to calculate the doses that I've given and divide by 24 hours. And then I'll see the increase. So that means I have to increase the dose. I want to give 10 milligram dose. For example, in 24 hours, I've given the 10 milligram dose, maybe 6 or 8 times. So that means 80 milligrams. So I divide by 24 hours and I get the dose, and that's the dose I'll give as I continue scoring the pain and see how the patient is doing. If not, if the pain is not controlled, then I have to call in the multidisciplinary team so that we review the pain and see how we can increase the dose and continue with the adjuvants. That is my point.
Thank you.
I don't
Thank
know
you.
whether it's clear.
It's very clear, guys. We have run out of time, and I hope next time this is a topic that we need to give more time. And I believe we will organize for that. So thank you very much, Dr. Julia. Thank you very much, Dr. Mfo. This was a very interesting topic, and you can see the way we are still thirsting to hear more from you. So at this juncture, I would like to welcome Charles from Africa Cancer Research, at least to give our closing remark. That's Muya.
Thank you, Pamela. My name is Charles Muya from Kenya Network of Cancer Organizations and also the Hub Coordinator for Africa Cancer Eco Hub. Thank you very much for joining us today, and thanks to our speakers for the wonderful discussions and the wonderful information that you've shared. So as Pamela mentioned, we are going to share the recording and slides on Basecamp for our reference. And we are also free to continue with our discussions over there once we post the materials. So our next session will be held on August 18th, and it will be the second part of our two-part series on strengthening palliative care services in the African region. And this time around, we are going to be focusing on psychosocial support. So please make sure you join us for that session as well. So we are coming to our Africa Cancer Eco year. So next session will be our last session for the year. And I think during that session, we are going to get more guidance on how the next year is going to be. So look out for the recording and set up for our next session. I'd like to hand over to Mishka in case she has anything to add. Thank you.
Thank you,
Welcome,
Charles.
Nishka.
Excellent.
Yeah.
Thank you. Thanks, Pamela, for fantastic facilitation today, and to Prof. Julia and Dr. Mfo for these great presentations, and to everyone for all of your questions. And yes, as Charles said, we're very excited to have this continuation in August 18th. So welcome to see you all then. And in the meantime, please stay well.
Thank you all. And I just want to say thank you, and looking forward to have you in the next session, and especially that one of psychosocial support to children. I know it will still be very interesting. So welcome all of you next time. I'm Pamela Were from International Cancer Institute in Eldoret. I'm a palliative care nurse, as well as oncology, and looking forward for more interactive sessions like this. I'm very, very happy about it, and I've really enjoyed. Thank you all.
Thanks, Pamela.
Bye-bye, everyone.
Bye.
Bye, everybody.
Thank you, everyone.
Bye.